I'll call to order the Green Mountain Care Board's hearing of March 26th. We have 3 agenda items today. The first is addressing a submission from UVM that came in yesterday. And we have hospital budget guidance for fiscal year 26, and then some rate review affordability guidance. So I'll take up the UVM submission first, and I'll provide a little bit of background. And I see that the UVM folks are here. I'll have our staff introduce the submission and give a little bit of oversight, and then we'll turn it over to UVM for any comments or remarks that they'd like to make, and then we'll go to board questions. So first, I just want to provide some background on the submission. In fiscal year 23, UVM had an $80 million budget overage. The board addressed that in an order last summer or fall, calling for an $80 million reduction in commercial prices spread out over 2 years, $40 million each year. The first $40 million price reduction took effect for fiscal year 25 and has been implemented. And then there's $40 million remaining of that overage. In fiscal year 23, there was an overage of $53 million. And the UVM submission addresses the remaining $40 million from fiscal year 23, and then the $53 million for fiscal year 24. Jessica Holmes and I, 2 board members, connected with UVM and some of UVM's leadership and board of directors to discuss the overage and to see if there was a path to resolving the overages in a way that was most beneficial to Vermonters and the state. And when I say Vermonters and the state, I mean patients, I mean other providers in the community, and I also mean UVM. A healthy and sustainable and productive UVM is a real asset for the state and important, as are our other providers. Member Holmes and I met with UVM leadership and board members for several months, I think 3 or 4, and there were some really candid and honest discussions, some very hard discussions, and a lot of understanding that went through that process. I found it difficult at times, but also really critical that we all roll up our sleeves on behalf of the state. And this ultimately culminated with UVM submission the other day that we have before us today. So I just wanted to provide that background so that everyone was aware, and I'll turn it over to our staff to introduce some of the key features of the submission from UVM.
Thanks, Chair Foster. I can jump in. As Chair Foster mentioned, in FY24, there was approximately a $53 million in unbudgeted NPR overage. The proposal being discussed today will resolve the appeals mentioned for the FY23 enforcement. Oh, Kristen?
This part was, we had a request to have the court reporter for this part of the agenda. Do we want to go on the record now?
Yes, please.
We're on the record.
So the proposal being discussed today would resolve the appeals and the FY24 overages by having the medical center fund the following: $11 million to primary care in FY26, $12 million to Blue Cross and Blue Shield to resolve allegations of overpayment from FY22 and 23, up to $15 million for consultants and an independent liaison to ensure the medical center and health network maintain and improve access to healthcare services while improving affordability for Vermonters. And it also establishes some additional criteria for performance-based or at-risk pay for senior executives. To do this, the Green Mountain Care Board will decline to take enforcement action on the FY24 overages and split the remaining $40 million from FY23 enforcement over FY26 and FY27. Previously, it was going to be applied just to FY26 only. So, Chair Foster, would you like me to bring up the letter or the agreement, or how would you like to proceed?
Why don't you bring up, so I think that we'll discuss today two topics. One is the sources and context around the fiscal year 24 budget performance. And then I think the board members and HCA and public may have questions or comments about the proposal itself. Why don't you turn just to the proposal, Matt, and bring that up?
Sure. Give me 1 second. You all see this?
Yes.
Great.
If you go down, Matt, I think some of the terms you described are later. So I can highlight a couple of the terms here. As Matt mentioned, there is $11 million that UVM would fund for non-hospital primary care. The mechanism to distribute those funds would be to be determined and figured out to ensure that it's legally compliant and appropriate. The next commitment would be a $12 million payment to resolve allegations from fiscal year 22 and 2023 that Blue Cross has alleged. That term would require sign off by Blue Cross and agreement that that's an appropriate resolution of their allegations. And additionally, UVM and Blue Cross are working and will continue to work on finding a methodology to prevent and avoid similar disputes in the future. UVM would file a proposed fiscal year 26 hospital budget that meets the Care Board's benchmarks in Section 1 of the guidance. There's some additional terms in here. You can read the details. One of the features in UVM's proposal is that the $40 million remaining from fiscal year 23 overage would be split out between 2026 and 2027. Currently, the board order calls for the $40 million to be addressed entirely in 26. This splits it out over 2 years. UVM's Q1 performance indicates that it is running a bit above its Care Board approved budget for fiscal year 25. And so UVM would seek a mid-year reduction to its fiscal year 25 commercial rate growth, if necessary, to comply with the board's fiscal year 25 budget. And then UVM and/or UVM Health Network would spend up to $15 million to fund a series of consultants to address and review various opportunities to ensure as cost-efficient and effective delivery of care and operations as possible. The $15 million number is an up to, and if it's determined to spend less than that amount of money, the remaining funds could be directed in a manner consistent with the agreement as directed by the Care Board after consultation with UVM Health Network and UVMMC. So what that means is there would be a work group contemplated by this proposal that would be comprised of 2 representatives from the Green Mountain Care Board, 1 from the UVM HN Board, 1 from the UVM Medical Center Board, and then 1 independent third-party liaison. And that work group would try to come up with an appropriate set of tasks and scope for RFPs for work to be performed by independent consultants reporting to that work group. And that would really be at how do we work towards ensuring appropriate Medicare cost coverage, appropriate growth, appropriate operations, all of those things as best we can for the state. Another feature in UVM's proposal is that the Vermont hospitals, if they choose to continue to use at-risk compensation for executives in fiscal year 26, at least 50% of eligibility for the at-risk pay would be based on material success in a number of areas. And if you go down, Matt, those would include reduction in ED utilization, New York hospitals repaying some due tos to the UVM Medical Center. the New York hospitals contributing equally to UVM-HN networks, and reduction in commercial rates and commercial revenue at or below 3 to 3.5% growth. I'm not going to go through all the detail, and UVM may have some additional things they want to discuss in here. The care board would have a couple steps that it would need to take as part of this resolution, including the splitting out of the fiscal year 23 overages. Last really salient point that I would like to raise from this is that this is still pending public comment and this board's regulatory process. 2 care board members did discuss this with UVM for, I think, about 3+ months. And the formal submission has been made, but the public has an opportunity to comment for at least a week. And it would still need to be approved by the board by 3 votes. And then the health network, and I believe the medical center board, would also have to vote to approve this. So this is a proposal. It is not approved by the medical center's board, HN's board, or the care board. So I'll leave it there. And Matt, unless you have anything else, I'll turn it to the UVM folks to describe their proposal in further detail.
I don't. Thank you, Chair Foster. Would you like me to leave the agreement on the screen?
Yeah, leave it there. And if the UVM folks would like us to move around what's displayed, we're happy to do that. So I'll turn it to Dr. Epp and Dr. Leffler and the UVM folks.
Thanks, Chair Foster. Sunny Epen. I'll start. Really appreciate your opening words as well. So Chair Foster, members of the Green Mountain Care Board, first of all, thank you. Thanks for allowing us the opportunity to join you today for what I believe is a really important milestone for both the University of Vermont Health Network and the state of Vermont. While UVM Medical Center is formally the organization that's submitting the proposal before you, it really affects the entirety of our health system and even beyond. And I want to take a few minutes to share with you our intent in filing this request before I really turn it over to Dr. Leffler to lead the discussions. I've really been fortunate to serve as the president and CEO of UVM Health Network for a little over 2 years now. You know, I'm not from Vermont, but I took on this role with great respect for this region, its culture, and an understanding of the role of our nonprofit academic health system and the role that it plays in our communities. In the time that I've been here, I've come to even better understand the deep challenges facing our state when it comes to affordability and accessing healthcare services for Vermonters. Meanwhile, all the state's hospitals, regardless of their financial performance or size, are dealing with the effects of increased costs for everything from pharmaceuticals to medical equipment to staff salaries. Combine these increased costs with our aging population and payer mix, it only compounds the affordability crisis with rising commercial insurance premiums. Last fall, we reduced administrative expenses and reduced certain clinical services. Those were difficult choices that we made, and we know the result has been incredibly challenging. Members of our community, members of this board, have lost trust in our decisions. A number of Vermonters have expressed fear and disappointment in our actions directly to me and to members of our team. I've been in healthcare for over 3 decades, and I can tell you, all of this begins with trust. Trust in the skills and expertise of your caregiver, your team. Trust in your hospital or clinic that they're going to be there for you when you need them. And most of all, trust in the others with your life. We know that Vermonters depend on us, and we take that responsibility very seriously. When that trust is compromised, we have an obligation to make it right. At our last budget hearing in August, I said that it would take a partnership from all corners of Vermont to make a meaningful impact when it comes to affordability and access. The actions we took last fall didn't live up to that statement. And we're here today with a proposal to increase our transparency and accountability. It's my hope that the initiatives laid out here in this plan that Chair Foster just highlighted and that we'll discuss in more detail will change course for our health system. It'll change course for our working relationship with the Green Mountain Care Board, and most importantly, It'll make care more affordable for Vermonters. Before I turn it over to Steve, I want to share my appreciation to our leaders, our Board of Trustees, and the members of the Green Mountain Care Board whose long informal conversations led to today's submission. We truly stand ready to work with you and everyone in the spirit of transparency and in the best interest of our patients. We're going to try to answer all your questions the best we can, and if we can't do it today, we'll get back to you as soon as we can. Thank you for your consideration. I'm going to hand it over to Dr. Leffler. Thank you.
Thank you, Dr. Epen. So first, I'd like to echo Dr. Epen's comment. I'd like to thank Chair Foster and the members of the Green Mountain Care Board for considering the settlement proposal we've submitted today. It's the result of months of hard work. I hope and believe that it led to better understanding and the beginning of a path forward to get on better track for the medical center network, but much more importantly, the Vermont patients that we serve and the state of Vermont. I've been at the University of Vermont Medical Center for more than 30 years, with the last 6 being its president. I'm honored and humbled every day to lead this incredible institution, a place of research, healing, and academic excellence that serves Vermont. I believe in our academic mission to my core and the important role that we play in the lives of the Vermonters that we serve. At the heart of this submission is a desire to do better and live up to the promise that UVM Medical Center stands for on behalf of our patients and all 8,000 of our employees. We know and acknowledge that we have work to do to earn back the trust that is so important to our success and for the overall health and healing of the patients and communities that we serve. To be very clear, this will be hard work, but if we can be better, we want to do everything in our power to get there. The Medical Center submission is a comprehensive plan to address affordability and access to patient care. I will say that Chair Foster and Matt did a good job of outlining some of this, but I'm going to quickly run through it with a little more detail, and then we're very open to any and all questions. So the initiatives in the proposal include $11 million in funding for non-UVM Health Network primary care providers for FY26. We're hopeful this funding will reduce emergency department visits that are more expensive for patients. $12 million to Blue Cross Blue Shield as part of an effort to settle their claims related to the UVM Medical Center charges from previous fiscal years. A commitment to submit a FY26 proposed budget to the Green Mountain Care Board that meets compliance criteria that's in compliance with the board's guidance. Additionally, we will do everything we possibly can to preserve clinical services if budget reductions must be made. There are significant funds in this proposal to hire consultants and an independent liaison to help identify new solutions to maintain and improve access to care and make care more affordable where possible. The 5-member work group will work over a period of 16 months to select and oversee consultants to make recommendations focused on maintaining high-quality care the health system provides while improving efficiency, affordability, and access to care. The group will be made up of 2 members from the Green Mountain Care Board or their designees, 1 representative from the UVM Health Network Board of Trustees, 1 rep from the UVM Medical Center Board of Trustees, and an independent liaison selected by the Green Mountain Care Board. Areas to be considered by this group will include administrative and shared service expense review, provider productivity and efficiency, service line reviews, our New York healthcare partners, and enterprise efficiency, among others. I really see this work as an opportunity to do better and drive down the cost of care. Additionally, if UVM Health Network chooses to continue with performance-based compensation for its leaders in FY26, we will work with the Green Mountain Care Board on a series of agreed-upon metrics for success. Finally, the proposal will resolve UVM Medical Center's pending appeals of the Green Mountain Care Board's FY23 budget enforcement order and its FY25 budget order, while allowing UVM Medical Center to invest much of its 24 budget overage in structural changes, some of which I've just talked about, that are intended to reduce the cost of accessible and high-quality care for Vermonters. As I've said, this work is extensive. We are committed to transparency and accountability. This proposal is meant to build upon trust and collaboration that will lead us forward, and to make clear to our patients, our staff, and our communities that we're willing to do what it takes to deliver the highest quality, most equitable, and accessible care at rates Vermonters can better afford. Thank you. We look forward to your questions, and we ask that after receiving public comment, the board will approve the agreement as submitted. Thank you.
Thank you. I'm just going to say a couple thoughts, and then we'll turn it to the other board members. At bottom, this is a bit of a trade-off for the board and for UVM and for the public. And really, I think the goal here is that this looks like it's really everyone trying to get together to come and think about the public and how we can do this best for the public. There is a trade-off, though. So the $53 million overage could potentially be fully enforced by the board, which would drive down rates and prices. And that is an option to review and evaluate. There's also this proposal, which has some components for driving down rates, some forgiveness of some of the overage, if you will. And I don't know if that's the right word, because we've not determined whether or not that a reduction would be appropriate at this time. And then there's investments to change and look at and evaluate operations, and some oversight that I think will help everyone build trust and confidence and look at things with a fresh set of eyes, as opposed to, a regulator and a regulated. And to me, that's ultimately the trade-off. There's some really important funding for primary care and Blue Cross. There's some retention of monies and some spreading out of monies over time for UVM. And really, there's a long-term investment in trying to right size and correct and do the best we can in terms of operations. And that, to me, is the decision point. And I just wanted to say that out loud and recognize that that's the trade-off that people are contemplating. And on the UVM side, they're giving up a appeal right, and maybe they would win their appeal, and we do the process over, and they're giving up some rights, and they're giving up some money. And that's really what everyone's trying to evaluate from their various perspectives. And that's the only comment I had. I'll turn it to Member Holmes, and I know the other board members may have questions or comments.
Sure. Well, thank you, Owen, and thank you also, to the UVM and UVM Health Network folks who came before us with this proposal. I will say, as somebody who was a part of this process, I really appreciate where we landed here. And I appreciated the UVM Health Network and UVM's desire to turn the page and to rebuild some trust. And I think this takes us a step closer. I support this settlement agreement where we landed. We're in a short-term crisis. It provides some relief to our critical primary care network, that some of whom are facing significant financial challenges. It provides some relief to our only domiciled insurer in the state who's facing insolvency. It does provide some rate relief through, some potential for a mid-year adjustment if they're running over budget for fiscal year 25, and potentially also in our fiscal year 26 due to the fiscal year 23 enforcement. For me right now, I think where there is real value is in this thinking through the long-term sustainability through having a liaison and having some consultants that can really help us understand and look at ways to evaluate the efficiencies and administrative costs and allocation of shared services, productivity, funds flow, all of that, I think, is going to give us some sense of how to move forward on a long-term basis to improve affordability for Vermonters and make sure that we can retain access to essential services. So those are some of the areas where I find there's promise in this settlement, but I am absolutely open to hearing, from other board members and the public comment on where this landed and how people feel about it.
Other board member comments or questions?
Sure. This is Tom. Thank you, Chair Foster, for kind of framing how the process has gone so far and the thinking behind it, and Jessica for sharing your thoughts. Thank you, Steve and Sunny, for the proposal and the willingness to work together, find a way to do that. I'm looking forward to hearing from my fellow board members their thoughts. I think to my read, we are at a crisis point that requires action. And this proposal outlines some action. I do have some questions about it because I do think there are trade-offs that are inherent, and I'd like to explore those trade-offs a bit. And so I'm not sure if this is to Sunny or Steve or Rick, but could you describe your process of deciding what's in the proposal? The primary, there's primary care, there's Blue Cross Blue Shield, there's consulting. I imagine there were other things that were considered. And I'm wondering if you could share with us what else was considered and how you arrived at prioritizing these items.
So, Member Walsh, I'll start. Really, this was a collaboration. So we had some ideas about what we thought would potentially help Vermont going forward. We agree that there's a crisis right now, and so we are very concerned about primary care in Vermont. This was a way to shore up that as we get to 27, and hopefully there's a head or some other method for them. We wanted to resolve or take steps to resolve our Blue Cross overage and have a path forward for how to make sure that doesn't happen again. This helped address that rather than having to come before the board to do that if we could avoid that. And lots of discussion with the Green Mountain Care Board members that we met with over and over around how to be more transparent, how to submit data that is more aligned with what you're looking for, how to build a path forward that would work for all Vermonters. And so the things in here, I would say every single one of them has some compromise in them. Every single one of them, somebody would have chosen to have them a little differently. But in the way Vermont does things, we kept working on it and kept working on the language. And I'm certain that every member that's on this call today or every person on here would have structured it a little differently. But this is where we ended up, and we believe this is a good compromise. We believe there's a path forward to improve affordability. There's dollars invested in making us more efficient. There's dollars invested in improving access and affordability for Vermonters. There's rate relief for Vermonters who desperately need that. There's dollars to our commercial insurer, to primary care. So this is a compromise. And like I said, I'll stop there, but every single item on here went through multiple drafts and revisions to end up here.
Member Walsh, maybe I'll even raise it up a little bit from my perspective. It was really trying to get to a structural openness to look at our cost structure for the greater good for Vermonters. And that is to say, like, we have to do something more than just hit the rates today. We wanted to fundamentally look at, are there opportunities for us to be less expensive in our structure? And I think the board members really pushed us on that. And I think this was an opportunity to kind of open the door and say, let's look at this together, because if there are opportunities, we want to take them. And that's going to be what's important for the long-term sustainability of lowering our cost and our cost structure and making that as transparent as possible. And so I think where we arrived is sort of taking care of the sort of acute immediate needs that I think everyone pointed to and Steve pointed to again, and looking at longer term opportunities for us who we think are so important to Vermonters and their healthcare access. How do we do this better? And let's open that up very transparently and look at that together and collaborate on that. I think at the highest level, that's what we were going for.
Well, I appreciate that. And as I said at the outset, I too am interested in how we can work together to achieve those ends. And as you, as current healthcare providers, you're constantly thinking about taking care of your patients and how that is. And as I'm no longer a healthcare provider, but as a regulator, I think of the people of the state and trying to keep their interests at the forefront of my mind, people who are unable to attend these meetings because of their work schedule or what have you, who is thinking of them as we go through this process. And so trying to imagine this, there's $53 million kind of at play, if you will. Another option could have been to return that to ratepayers or to lower commercial prices so that things were more affordable immediately. And I think this is a story of trade-offs, and how are we trying to meet the aims of caring for patients the way that you've talked about, caring for your community, and considering taxpayers and commercial ratepayers. So I think that's the hub of the trade-off here is there's 11 million toward primary care. I think that that's obviously important. Our 12 million toward Blue Cross Blue Shield. I think if I were trying to talk across the kitchen table to a relative, that would be a stretch to try to explain why I would prioritize that over immediate rate relief. But I think I could get there. I think I could help my family member understand that if the insurer were to become insolvent, that would make everything much more expensive for everyone right away. And it would threaten our healthcare system fundamentally. I think it gets a little bit harder to explain across the kitchen table to the 15 million for consulting. That seems like a large number. I think Jess, Member Holmes, outlined how that work gives us insight into all of us, medical center, health network, care board, insight into the structure and function of the network, something that we don't have a lot of insight into right now as regulators. And there could be a lot of long-term good that comes out of that. The 11 and 12 and 15 added together come to $38 million. We have 53 at play. It's not clear to me from the submission where the difference is going. There's apparently 15 million still that I don't see accounted for. What is the plan for those dollars?
So that 15, so thank you, Member Walsh. So I think you described the balance we were trying to reach in this proposal, some money for primary care, some money for our commercial insurer, some investment in future to try and drive down the cost of care, which is truly an investment, and some money to the medical center to retain to soften the pathway as we're trying to get cheaper and more efficient. So there are dollars that the medical center does retain that were in there. That's the difference between the 38 and the 53, which is 15 million.
Thank you for clarifying. And I understand your perspective trying to run the network, the medical center, and trying to balance your books. And I imagine you can understand mine trying to explain to my family member across the table that 15 million returned or staying with the medical center that may have been used for rate relief, that's a trade-off that needs to happen. I think I'd struggle with that argument. I understand the consulting is up to 15 million. And if it can be done for less, that money could be used for rate relief or in some other fashion. I think from a process standpoint, we're talking about this in public now. There'll be a week of public comment. We may be voting next week. I think the trade-off, making this the trade-off that we're talking about explicit is important, because I think taxpayers and commercial ratepayers have borne the brunt of the high commercial prices. And we're giving up some relief to them in this trade-off. And it occurs to me, reflecting on this, that the folks who are giving up in that way were not at the table to arrive at this proposal. They may have guided us toward different choices, or their input may have influenced our choices that are here. And as the WCAX last night, this morning said, what we're talking about is an agreement where prices will not come down as far as they might have. That's the quote from the newscast. So those are the things that I'm considering. And again, I realize that this is a moment of crisis. My preferred method for doing something like this would take even longer. I'm not sure that's a good thing at a moment of crisis. My preferred outcome, the total being returned to ratepayers, it's unclear that we could get there, that there'd be enough votes at the board for such a thing, that the board would approve of full enforcement. There would be unintended consequences, I'm sure, from continuing to butt heads as we have. So that's the way that I'm looking at this trade-off. I appreciate the opportunity to describe that and for you all to listen. And I'm looking forward to hearing from fellow board members, members of the public, and any comments you all have back. So thank you. Back to you, Chair.
I'm just going to open up to other board members as we go, if others have questions or comments.
I can hop in. I have a few comments. I don't know, just a few questions maybe, but I just want to start by saying I do really appreciate the sincerity of this attempt of coming to an agreement, and really how that's reflected in the submission. I really appreciate Dr. Epen and Dr. Leffler, your comments here, and Owen and Jess. I know that you've put I know you've all put a lot of time into this to try to come to a pathway where we can work together to deal with a lot of these challenging issues. I'm just going to talk about a few things in here. I appreciate, Tom, I really appreciate your analysis of this and the questions that you asked and your perspective on this. And I share many of those. I do think this is a balance of trade-offs. I think everyone here is looking at it that way. I mean, on all sides of this. So I guess that's inherently what a compromise is. Some of the areas that I have a little bit of challenge with that I'm trying to understand is the splitting up of the residual enforcement from the FY23 overage over 2 years. So that would split the price reduction of $40 million over 2 years, which would basically allow for another $20 million of revenue due to price to come into the medical center for FY26, and then extend out the enforcement of FY23 to FY27. So about 5 years from when the decision was made to the resolution of the enforcement. It definitely carries that out for a long time, and that does. I look at that as another $20 million retention by the medical center because of the way we would divide that. I think that makes me think of this as more of a $35 million retention as opposed to a $15 million retention. And so that just gets into my view of trade-offs on this. The one question that I had too, which there's been a little bit of differing comments about just during today's hearing, is regarding the compensation. Sorry, let me just flip to the correct page here. If the UVMH and Vermont hospitals continue to use at-risk compensation, but I think Dr. Leffler, when you mentioned this, you talked about the UVM Health Network. Does this apply to UVM Health Network at-risk compensation for senior executives, or just UVM Vermont hospitals?
Both.
Okay.
Member Merman, all the leaders for the network and the Vermont hospitals.
And I think really what I'm interested in here today is hearing public comment on the topic too, to help guide my my thoughts on this. But I just want to reiterate, like I really appreciate all of the work, time, people letting go of positions to come together to an approach of a compromise pathway forward for Vermont. So thank you.
So I'd just like to make one comment to Member Walsh and Merman. There was cost involved in providing that care, the 80 million. And so spreading it out over a longer period of time helps us drive cost out of the system to make it more affordable. So it really lengthens the time. It gives us a little more runway to bring our costs down to where they need to be. So I'm sure we could spend a lot of time on this, but doing it over 3 years instead of 2 just allows us to be more gradual and thoughtful in how we get those costs out to be more sustainable going forward.
I appreciate that, Dr. Leffler, and the trade-off about the thoughtful approach and the benefits that could come from that. I'm not doubting that. The trade-off is more rate relief sooner, and so that's the tension, right? And it's so
I understand that.
Yeah, and I understand you. So thank you.
I'll go ahead and jump in. Thank you, everyone. I appreciate all the hard work that has gone into this proposal, both from my colleagues here at the board and those of you at the Health Network and UVM Medical Center. So thank you for that. I appreciate the hours that you spent together trying to hammer something out. So I just wanted to make sure that I was understanding some of the additional material that was submitted that we haven't touched on. So in terms of the fiscal year 24 NPR variance, we've been talking in the proposal about revenue overages. There hasn't been a ton of discussion yet on expenses associated with that revenue, but it looks like from your submission that for the 24 overage, the margin impact was about 6 million. So from that, let me just make sure I get the number right, 53-ish million overage, the money that was made, if you will, was 6 million. Am I getting that right?
Rick Vincent, can you confirm? I think that is right, but Rick, can you address that?
Yes, Member Lunge, that's the estimate that we came up with.
Okay, thanks. In terms of the 11 million for primary care, I totally understand folks are trying to figure out the right mechanism for pushing those dollars out. But I'm wondering if you have any thoughts on how that might happen. Understanding that this isn't set in stone, I'm just curious as to what's been thought of to date.
So we basically want to make sure that we do it in a compliant way. It doesn't have any issues with Stark or kickback. Luckily, Chair Foster is an expert in that. And we really would like to make sure to tie it to some ways to make sure that we improve affordability for Vermonters. And it's only for a year, but some sustainability for primary care through a difficult time. So we agreed there's more work to be done there, but I'm very confident that we can come up with a proposal that will meet those hopes.
Okay, is the blueprint on the table as a possible mechanism?
I actually can't answer that. I think anything is potentially on the table. We
Okay.
want to make sure the dollars flow. I don't think we have any commitment to exactly how it would work.
Okay, all right, thank you. I think I'm good. So thank you.
Any other board member questions or comments? And we may have, I have one or two small follow-ups on the source of the overage that I'm probably going to just have staff send in writing. So I apologize for not having that together, but there was one or two things I wanted to clarify, and I'll just send staff, will send something. Any other board member question or comment at this time? I'll turn to the healthcare advocate.
Good afternoon, everyone. I will echo what everyone else has said already about appreciation for the hard work, both from the board members and from UVM Health Network. I need to make a comment about process. I want to both recognize the motivations, the noble motivations on the part of the board members and UVM Health Network to come to an agreement and not to continue attempting to enforce and litigating over those enforcements. Moving away from that, I get it. We're in a time of crisis and we need to move away from that. And at the same time, I need to express an unease with the process. And the public's ability to really engage and have a meaningful, and then my office's ability to have a meaningful impact on what's before you. The way it looks to me, there's not a lot of opportunity for a meaningful impact on this. So I need to name that. I appreciate Member Walsh's discussion of the trade-offs. I was having similar thoughts and would like to at least echo his comments about deliverables for Vermonters today. If I had an ability to influence what's before you today, I would attempt to move towards more immediate rate relief for Vermonters. I appreciate what's in there. There is stuff in here that does go to Vermonters' care. I recognize that, but I would have done more, or would call for more, I should say. Okay, question or two. First off, just a clarification, Dr. Leffler, I think I heard you say that the $11 million primary care goes to non-UVM primary care, but I think it is in the agreement non-hospital primary care. So I'm just want to double check that I'm understanding.
It's non-UVM primary care. Eric, I have that right, correct? Or it's to fund the rest of the state primary care, not the medical center networks.
I think it says non-hospital.
Okay, I just wanted to make sure we're all on the same page on that. And I was going to go down the same track that Member Lunch just went down about delivery of those dollars, so I won't repeat it, but just to express a concern that be done and be done effectively. Appreciate that there's more to do on that to make sure it happens. I also want to recognize the $12 million going to Blue Cross. Will go to Blue Cross entity-wide. and I understand why they would go to Blue Cross entity-wide, but I'll just state a particular concern for affordability in the QHP. But I understand that to the extent that there may have been overcharging, that happened throughout Blue Cross's entire book of business, including self-funded. But if I could have my way, and so I recognize the problem with my argument here, but if I could have my way, I would attempt to focus it on QHP affordability. Lastly, I want to just focus on the liaison for a minute and ask if anybody knows the answer to this. Well, first off, how is the liaison going to be chosen? If anybody knows. I mean, I understand the board is hiring the liaison, so is there a process envisioned for that, or?
I can answer. I think it's in the document. Matt, would you pull it back up? And I think we can clarify the non-hospital versus non-UVM thing. I'm familiar with the documents. I'm pretty sure it's non-hospital. And then the liaison process is that I just want to make sure I get the right language. Okay. Yeah, section 3, Matt. Okay. Go down. Oh. Maybe down a little bit more. Yeah, section F of section 3. And the proposal reads, the Green Mountain Care Board will select an independent liaison to assist the work group in carrying out its responsibilities. The independent liaison may choose to hire 1 or 2 professionals to provide additional needed expertise, including hospital operation and/or financial experience. UVM and Medical Center of the Network may make recommendations as to the selection of the independent liaison and the other professionals. The independent liaison and other professional will receive reasonable compensation to be drawn from the $15 million pool. Independent liaison and other professionals will have no media communications unless specifically authorized by the work group. And then it provides some of the scope of the liaison's work. So the way it reads is that UVM can provide input to the care board and as to the liaison and also to the others, but that it's the care board's selection and that UVM will fund the work.
Thank you. Do you want to address the primary care piece as well, or?
Yeah, now would you go up? I think that's in one of the earliest sections here. Yeah, right there. Okay. UVMMC commits to fund non-hospital primary care providers. So it wouldn't be Rutland's, well, not Rutland, but another hospital's primary care. I think the intent behind this was to provide a bridge and assistance to those primary care providers who would be losing out of that amount of money in the gap year between the all-payer model and the ahead model if the state goes forward with it.
Okay. So I have some concern about the transparency of the liaison's work and the ability of the public and the HCA to have insights into the findings and work of the liaison. And so I wanted to express that and maybe to ask a question in line with that. I don't know that anyone's going to be able to answer this question, but H482, the emergency powers bill that is passed the House and is in the Senate, lays out some more structure about. I don't think it was called liaison in that bill, but the same mechanism and sort of the transparency of that. No one may be able to answer the question, but should that bill pass, would those statutes regulate this work, this liaison's work?
I think the answer is I'm going on a limb because I haven't reread that in a little bit. So don't cite this back to me if I'm wrong. And the bill could change. My short answer is I don't think so because of the effective date and then the triggers to get the observer in those bills. And so there'd have to be a finding of a budget violation and or a misrepresentation is I think where that bill landed. And then there's the effective date component to it. I don't think this excludes that should that process later happen, but I don't think that that would govern this. This is a settlement. So no, I don't think it would govern.
All right, well, I'll just close with an expression of concern around that topic and a strong sentiment that as much as possible, understanding there'll be confidential materials, but as much as possible that the liaison's work is viewable by the public and that the HCA have some insights as well. Thank you, Mr. Chair.
I think there is a provision in there about public records laws and the like in that document. I don't have it off the top of my head. I'll open it to public comment. And I'll note that the public comment, we have noticed a vote for next week. I would like to do the vote next week. That is our anticipation. But the public comment period is open. So if people want to review all of this in more detail, I think this was just posted yesterday. There's time to do so and to provide additional thoughts. Hey, Walter, I saw you come off. Hey.
Hey, Owen.
Hey.
Public comment. I just barely had time to read all of this stuff before the meeting because I've been at work for the last 4 days. I'm curious why we need another, we just hired a consultant. Do we need another one at 15 million, which is about $1 million a month? Every time I hear people talk about affordability, price drops, prices go up. So I get a certain chill up and down my spine when I hear that because no one's defined what that is. And you say this is a compromise. To me, this is like a charm offensive. I'm a little nervous about that. And I echo a great many things that Member Walsh and Member Merman and Mike Fisher spoke about. So I won't reiterate those, but I'm really nervous that the public wasn't involved in this since we're footing the bill for all of this. And we're the ones paying the rates, paying the fees, paying the taxes. And in the end, I also saw no provision, and I may be wrong, governing the bonuses to UVM CEOs. And I'm always curious why they need bonuses in the first place, considering they make so much money to begin with. I'll end it there. Hope I get that line down.
A couple of quick things. There is a provision as to bonuses. It's not reducing bonuses or prohibiting them. It is aligning them with more in alignment with the state's goals. So one of them would be reduction in commercial rate and or limited commercial growth, which would help the consumer. So there is an effort to align the bonuses. This doesn't say you can't pay the bonuses, but it does align them at least, I think, with a more intentional way for the state's interest. In terms of the public comment process, I agree. Member Holmes and I met with UVM and many, I guess I'll call them private, but we certainly didn't invite the public. I will say I have dozens of meetings a week where the public isn't there. This is the process and the time for the public, and it's up for a week. We made sure we had at least a week. We wanted to do it sooner, but there was a lot of trade-offs and back and forth. So I do think the public should take advantage of every opportunity we have. I know that UVM put out media and some media has covered it. So hopefully there's pretty good awareness. It's been on our website. So this is the opportunity for that and to frame our minds to impact us, just like any other process. But I will acknowledge that we had, I don't know how many, maybe a dozen meetings before this with Member Holmes and I and UVM. And then, I'm not trying to defend UVM, and I think that they made a statement, and I take them at their word. It's hard to say those things and acknowledge some of those things. So is it a charm offensive, or are they trying to turn the page, right? And how do you distinguish that, right? And I think we have to see the actions back up the words, and that's what I think we all have to evaluate. Are the actions there? Or is it just words? And I've been working with UVM on this, so I'll take them at their word that they really mean this, and that they're taking the steps to do it. So I'm not trying to defend UVM. I'm just acknowledging that they said the words, and we have to presume they mean them. And then we look at the actions and see if they're backed up. And that goes for everybody.
That's why I asked the question, Owen. The words have to be backed up. They haven't done it before, so.
Agreed. You need to let
Agreed.
people. Well, I don't actually mean that. So what I mean is let me move on. The point is you have to give people an opportunity and let them walk through the door and open the door and take different actions. And this is a step, and we and UVM and the public we need to rebuild trust across the system. And that's what we're trying to do, I think. Dr. Golper?
Thank you. Does Blue Cross have cash reserves, and might they be used in this crisis?
No. No, they don't.
Okay.
Hey, Alex, how are you?
Well, I am kind of upset, to be honest. I read the UVM letter this morning, essentially apologizing and saying that there is no trust. And I think the trust will start to grow when the premium rates go down. And again, sorry, I'm the PT billing person. I have the rate sheet from Blue Cross last year. A family plan, which I do want to eventually have a family in Vermont, is $38,000 to $44,000 on the Health Connect. There's 70,000 people that are on the Health Connect. I've listened to the legislature talk about the premium tax credits can go away. That's $311 million. If that goes away, a lot of people in Vermont are going to go uninsured, and the whole state economy is going to collapse. Other things, I looked through all the documentation on the Green Mountain Care Board website. I saw that a travel nurse expense per hour is $211 versus an in-house UVM nurse is $121. Again, earn trust with your employees by giving them raises so we don't have to hire travel nurses. Please, I'm begging you. UVM left the Seoul Community Hospital status so late. We're years behind. Now my assumption is over $200 million that we missed out on. And in the agreement that was posted, it says that UVM will follow the guidelines, but their public comment for fiscal year 26 is already saying that they can't meet the 3% threshold for expense. And lastly, I see Ms. Champney's not on this call. I'm begging UVM to give me their Cigna contact person, because the contract people that I have to deal with are in the Philippines and India, and they are not letting us go in network directly with Cigna. We have to go through a third party. I cannot stand what they're doing to the PT profession, and UVM is treating them as equals to Blue Cross and MVP. If they knew what I knew, they would not do that. I'm just so frustrated, and I have to explain to my employees what's going on. And my mom, who owns the clinic, was calling senators and House members to get a Medicare increase. No one answered. I'm just beyond frustrated, and I want to explain to my employees how we're going to afford a health insurance plan when these tax credits go away next year. Thank you.
Thanks, Alex. We are all hyper concerned about some of the federal changes, and that's not an answer. There might be more drastic steps that the state and the healthcare system writ large, not just UVM, needs to take really urgently because of this. And I try not to be hyperbolic, but the concern about sustainability of the system and the economic destruction that can cause a 15% rate increase can cause is real. And it is a bit of a, you lose people who are healthy lives because they can go without insurance. And now the QHP plan just has the really, really sick pool, or people who can't afford to get an ASO contract. And that's just a spiral that's really, really difficult. And if businesses like yours have a 15% rate increase, you can't expand, you can't grow, and it is a really tough spiral. So the state for a couple of years has been looking for solutions, and this isn't going to be a panacea. This isn't going to solve it. It's a step, and maybe it's the right step, and the public input on maybe it's the wrong step is probably fair. There's considerations here and trade-offs. But you're right. The concern about the system and what's going to happen is real, and it's a bigger conversation than this meeting and this proposal. Lexi Krupp.
Hey, thank you. I was just wondering how that $15 million figure sort of came about. My understanding is the Oliver Wyman report cost around $1 million. So I'm just curious, yeah, is the scope of work here like 15 times what that was? Yeah, if you could just provide any more insight behind that figure.
I can give you some quick thoughts, Lexi. So it's not a hard and fast figure. I mean, that number could be 3 million, it could be 12, it could be anywhere in between. And that's what the 5-member work group will try and get right. It is very expensive to review the types of things that are within the proposal, right? You're talking about really significant governance change evaluation and recommendations, implementation of service line evaluations and changes, cost structure, administration structure. All of those things are different buckets that can be very, very expensive if you hire excellent people. And this would take excellent people. So it's not one consultant. It might be 5, it might be 1, it might be 3, and it might be 3 million, or it might be 15. And the remaining money will be used to other purposes if there is any. So I think it's a cap, not necessarily that's the number.
Thank you.
Yeah, just to a little bit more of a fine point, before you actually put out an RFP, you don't know what these things are going to cost. So this is a placeholder in a way to try and identify and get the right mix of services to drive down some of these costs and provide some rate relief. Julie Wasserman.
Yes, pardon me. I'm listening intently, trying to understand. But Lexi Krupp's last question triggered me to make a comment, which is, can somebody help me understand why we Vermonters, we ratepayers, are paying up to $15 million for UVM Health Network to get its house in order? That just doesn't quite make sense. It's like they have made decisions over the last 10, 15 years, and we're paying for them now. And now we're going to have to pay for them to correct that. It just seems backwards to me. So it's just a comment. And I probably will write much more in my public comments, but even though it's a very short timeline, I'm a little concerned that 1 week it does not give enough time for people who are not completely engaged in this process to weigh in. But I would just like to make that one comment for now. Thank you.
I'll respond, and I appreciate all the public comments you give and written and otherwise, Julie. So I'm looking forward to it because it is always a good perspective, and maybe we think of things differently. I think at bottom, we ultimately as Vermonters pay for every single thing at every single hospital, really. Like unless it's like Medicare or donations from out of state, we pay for everything. It's Medicaid, it's our portion of Medicare, it's commercial. It is ultimately all funded by the public. So this isn't, I don't think of it as necessarily paying additional money. There's a chance that UVM wins appeals or the board doesn't take action on this $53 million, in which case you already paid for it. The UVM would have the money. It's really how are you using the money? And are you using the money to drive down rates? Are you using the money, letting them keep it for the care that was provided for the expense? Is it being used for the consultants? Like it's all ultimately funded by the public writ large. There's no real private money here. Any other public comment? Jesse, and if you wouldn't mind, Jesse, would you identify where you're from so people know?
Sure, that's kind of why I thought I'd raise my hand. So I'm Jesse Bridges. I am the chair of the UVM Medical Center Board as a volunteer. And in my other day job, I am the CEO of the United Way of Northwest Vermont. I wanted to make a comment about, we're talking a lot about process and public process, and there's been a lot of talk about the health network leadership and the medical center leadership and the Green Mountain Care Board. I think it's important for the community to understand that there are also other community members. There are boards of the medical center and boards of the health network. As nonprofits in this community, and I run a small nonprofit, volunteer boards play an incredible role in connecting community and providing accountability and support to organizations to do this incredible type of work, whether it be to support their employees or to support their larger mission in supporting the community. I think this work that we've done, both with board leadership, the care board, and the hospital network leadership, shows just an incredible progress in how we all can work together. I think can illustrate for other sectors and other areas potentially how to work together. And find ways forward. And I know I speak on behalf of my other volunteer board members who represent other nonprofits, small businesses, community members across Vermont. We really believe in the quality of the healthcare in our community. And we know we have work to do as a community to figure these things out. It's not just healthcare, housing, our school structures. Vermont, we have some work to do. I'm really impressed by and proud of all of my fellow Vermonters who are volunteering to stick up and stand up and be part of that process. So know that the boards are committed to doing this work alongside the rest of the community in Vermont, the difficult work ahead. We look forward to continue to be part of this process.
Thank you. Ms. Wasserman, I think your hand's up. I don't know if you have more comment you'd like to make.
No, thank you. I got to take my hand down. Thanks.
Any other public comment at this time? Okay, great. Well, thank you everyone for attending and for the comment, and UVM for the proposal, which we will continue to review. I'm going to take a quick little 5-minute break before we go to, I think guidance is next. Lexi, did you have something else?
Yeah, actually, sorry. I was just wondering, is there going to be any process for a potential revision of the proposal, or is next week's vote like as it stands now or nothing?
Good question. I don't really know the answer. I think certainly it's a UVM proposal. If they want to change the proposal in response to public comment or their own discussions or board member feedback, they can. If board members throughout this process want to make different recommendations and see if it's something that's better for the state, we can. But barring that, I think we have a proposal and we'll evaluate it and we'll go from there. Dr. Leffler?
Yeah, I just wanted to express my appreciation to the Green Green Mountain Care Board for the work on this, for considering this proposal, understanding the balance we're trying to strike here, and for the collaboration. So I just wanted to make sure that everyone knows we're very appreciative of this opportunity to come before you today with this proposal, whatever happens. Thank you very much. And we appreciate the public comment, and we are committed to doing everything we can to address those concerns.
Great, thank you. All right, we'll take a 5-minute break. We'll come back at 2:22. It looks like everyone's back. We can resume our meeting, and I'll turn right to Matt Sutter and the Health Systems Finance team.
Thanks, Chair Foster. Can you see my slides?
Yes.
Okay, great. And you can't see my notes? There are no notes, but you can't see that anyway. I always get confused with the PowerPoint presentation.
Don't see any notes.
Great. So thank you. This is the third in our series of hospital budget guidance meetings. We have a pretty short agenda today. Just a quick timeline. We'll review again the timeline for hospital budgets. Look at the hospital budget review statute and rule. Then I'll quickly go over themes from public comment this year, some big picture changes we made to guidance since its initial presentation in February, and then we have some motion language for a potential vote. So draft guidance was initially presented on February 19th with public comment period running from then until March 25th, yesterday. A meeting was held on March 12th to present an updated revised draft of guidance. This meeting today is to present the final recommended budget guidance to the board for a potential vote. Just a quick reminder to everyone up, anyone to call up to speed. Annually, the board shall establish a budget for each hospital by September 15th with a written decision by October 1st. The board may establish a process to define on an annual basis criteria for hospitals to meet, such as utilization and inflation benchmarks. The board may waive one or more of the review processes listed in the statute. Established budgets shall meet the requirements of this section, including that they, quote, take into consideration national, regional, or in-state peer group norms according to the indicators, ratios, and statistics established by the board. GMCB rule further established that these benchmarks for any indicators for hospital use in developing and preparing the upcoming fiscal year's budget. Rule 3.202A says, requires us to meet with VAs and interested persons to obtain input on the benchmarks, and that benchmarks must be established and provided to hospitals by March 31st. The benchmarks allow the board to determine whether to adjust the hospital's proposed budget, and the board can set benchmarks for growth indicators, cost and price indicators, and other financial measures recognized or used in evaluating budgets or financial plans. As of noon yesterday, we'd received 5 public comments. Themes were generally around recommendations for additional quality metrics. There were a number of formatting issues identified, requests for increased clarity of some descriptions, technical changes to the supplemental workbook. There was concerns about commercial reimbursement rate, adding and regulating. There was a suggestion to add and regulate off of a commercial.
You went on mute for me anyway.
Shouldn't be. Can you hear me?
There you go. Yes.
Okay.
Yeah.
Might have been a technical issue. I apologize. A suggestion to add and regulate off of an NPR cap rather than overall NPR cap, and for clear budget orders. Changes made to guidance since the initial presentation can be found in detail. We have a change log posted to the webpage, and there's a link in the presentation to it. But we did add additional quality sources and clarified some measures. We've added clarity to productivity data, enhanced clarity of descriptions and processes in the guidance document. We've addressed some formatting issues and improved timelines and requirements around the submission of materials. And so we do have potential motion language, Chair Foster, but I will turn it back to you for how you'd like to proceed.
Yeah, no, thank you. Just open up to board member questions and comments, and then we'll take public comment. Actually, why don't we do board member questions and comment, and then I'll read the motion, and then I'll take public comment. All right, hearing none.
I was waiting. Sorry, I do have a couple questions. Sorry about that.
Gotta go fast. I'm keeping it snappy these days.
I guess so. So Matt, I was curious because in the guidance, the description of the network supplemental material is sets a threshold for which networks would need to submit. And certainly I noticed in the workbook that UVM was included in that. Do we know Dartmouth's percentage of revenue that the Vermont hospitals are? Like, do we have a way to assess their compliance with that? Should it apply to them?
Yeah, I want to say, and I shouldn't do this and make a number off of my head. I want to say it's around 10%. The Vermont hospitals represent around 10% of Dartmouth's revenue, but I could be corrected. I hope I'm not wrong. I think that's about the scale of it, though.
Yeah, I was assuming it was well below 50, but I just wanted to check to make sure we had some way to assess that. Thanks.
Yeah, we can use the audited financials. It wouldn't be the most up to date, but it would give us an idea. We can look at Dartmouth's audit and the consolidating statements and that.
Great, thank you. On the contingency plan tab in the workbook, so it looks like what you're trying to get at here is any contingencies in terms of changes in particular dollar amounts as a contingency target for budget. I tend to think of contingency plans as being more qualitative. So I wondered if you could just speak to that a little more specifically.
In what? I'm sorry, Robin, what?
No, that's okay. So there's a tab, I think, in the workbook about contingency plan that asks for dollar figures. When I think of a contingency plan, I think of, maybe a qualitative plan for how you reduce expenses or something like that. And so I just wanted to understand what you were looking at so that it was a little clearer to me.
Sure. So I think the idea is we're trying to tie actual dollar amounts to planning discussions about any changes at the hospitals. In the past, when we've asked for these kinds of planning type questions, we tend to get a real mixed bag of responses. So just trying to make it a little bit more quantitative rather than qualitative opining.
Okay, thanks. Those are my two questions. Thank you.
Anyone else? Okay, I'll make the motion and then I'll open up to the HCA and public comment. I move that the Green Mountain Care Board approve and adopt the fiscal year 26 hospital budget guidance as presented by GMCB staff, which includes benchmarks for one, net patient revenue growth at no more than 3.5% over the fiscal year 25 system-wide established budget, commercial reimbursement rate growth by payer at no more than 3% over fiscal year 25 established budget, and three, operating expense growth at no more than 3% over the fiscal year 25 system-wide established budget, in each case as presented by GMCB staff and reflected in the fiscal year 26 guidance. The fiscal year 26 guidance shall be effective as of March 31st, 2025, and the GMCB Director of Health Systems Finance is authorized to finalize and issue the guidance on or before that date. I have one comment. Sorry, I'll see if there's a second.
I'll second.
My only comment on this is I know that these are targets that will not be that simple or easy for some hospitals. And at the same time, we are in a serious affordability crisis for our state. And a lot of hospitals, some hospitals have seen significant expense growth and commercial rate increases over the last several years. And it's already in the base to some extent. I think this guidance balances the affordability crisis that consumers are having, the need for others in the system to have an ability to obtain the rate increases that they need to sustain their operations, and at the same time giving hospitals what is a reasonable amount of increase in the guidance. So I support the guidance and I appreciate the staff's work, and I really appreciate VAHS and the hospitals working with our staff on this guidance. Any other board member comment or questions on the motion? I'll turn to the HCA.
Thank you, Mr. Chair. the HCA submitted a written comment a little over a week ago. And so we stand by that comment. There's no need to repeat any piece of it here now. But I will just make a high level comment that the HCA believes that we're going to have to approach this effort in a different way in the future. This clearly is not the year when we're going to change the approach, but we think that if we're going to get some different results out of the process, we're going to have to change the approach, and look forward to discussions in future years to move towards that. Thank you, Mr. Chair.
Thank you. And fair point. I've been hearing from the business community that this is too much. We actually have to go the other way. And, you know, it's actually not a totally incorrect position. It's a challenging position, but that is some people's view that we're too high. Nonetheless, I support this at this time. Any other public comment via raise the hand? Oh, sorry, Dr. Merman.
Can I just ask one quick question on this? And maybe I'm just thinking about this for the first time, but when we say system-wide established budget, are we referring to an individual health system? Or the broad health system?
Defer to Mr. Sutter.
Yeah, I'm sorry, in the third one, system-wide. So it's, yeah, so the way we modeled the expense increase, 3% system-wide. We apply the benchmark evenly for all the hospitals. That's why the system-wide language is in there. Obviously, individual hospitals submit their individual budgets and will be considered against that. But in establishing a benchmark, especially with considering affordability, you kind of look at it as a system-wide number. But yeah, they're all judged individually.
Thanks.
Mr. Del Trecco.
Good afternoon. Thanks, Chair Foster and members of the board. I submitted comments today, so I appreciate the opportunity to submit them. I proposed some moderate adjustments, and I want to key in on operating expense for a minute. You know, I proposed some ranges, and the range on operating expense is 3.5% to 4%, 4.5%. And the reason why is there are existing contracts in place today, multi-year contracts that hospitals could have the opportunity to go back and renegotiate, but there are some contracts related to clinical salaries that are multi-year and well above the 3% threshold. So that's why I offered a range of 3 to 4.5%. The other thing that I suggested, and maybe this is an opportunity, is could those clinical salaries associated to multi-year contracts be held harmless from that 3%, putting, pressure in the areas of, I'll call them vendor contracts. So certainly an opportunity to think about things. As you alluded to, these proposed benchmarks will be very difficult to achieve. And my comments and written testimony really reflect our desire to comply with the guidance, knowing that it maintains a clear mandate around affordability and offers support for quality access and work around transformation to occur at the same time. There are costs associated with those things, and that's the spirit of which I submitted my comment letter today. So thanks for the opportunity. Happy to answer any questions that you might have, but the spirit is we have some things that are in place that go well beyond already this target or benchmark, and will be very, very difficult to achieve on face value nonetheless. So thank you.
Great, thank you very much. And I received your letter this afternoon and gave the read, so thank you for submitting it. Any other public comment at this time? Ms. Peakley, how are you?
I am well. Thank you, Chair Foster. And thank you for this opportunity to speak. There is alignment within those that provide care to Vermonters and those who want to ensure the affordability of that care. I'm very pleased to see that alignment. I would echo Mr. Del Preco's comments about the areas that already have, in our expense categories, already have contracted agreements regarding wages and various increases, and we respectfully request that the board allow sufficient time for the staff to fully understand what that would mean in terms of the currently proposed 20% increase in year-over-year expense cap. So I respectfully request that we allow sufficient time for that review and am certainly happy to assist in any way possible. Thank you.
Thank you. Other public comment? Dr. Weigel?
Thank you, Chair Foster. Just to highlight one thing that was in our public comment letter, the NPR cap is not payer specific, which could allow commercial payments to increase more than the NPR cap, which has happened in many of the past years. So to address this, we did propose implementing a distinct commercial revenue growth cap for each hospital. So just restating that. Thank you.
Thank you. And for the record, Dr. Weigel's from Blue Cross Blue Shield of Vermont. I will say that I anticipate having a commercial revenue cap in the budget orders as opposed to simply an NPR all payer cap. It really should be payer specific so we don't have some of the affordability challenges going forward. Okay, thank you for the presentation, Mr. Sutter. The motion's on the table. All those in favor say aye.
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 I'm going to abstain because I won't be here for the budget hearing. So I wish everybody the best of luck.
Lucky you, Member Lunch. Aye. The motion carries 4-0 with one abstention. Next, I believe it is our General Counsel, Mr. Barber, with a presentation relating to affordability guidelines and guidance.
Hi, good afternoon. For the record, Michael Barber, General Counsel. Just give me a minute to bring up the document. Okay, are you able to see that?
Yes.
Okay, so I'm here to speak about some proposed rate review guidance, or might be more accurate to describe it as interrogatories that the board might want to start asking insurers as part of the individual and small group rate filing process. So before I begin, I just wanted to recognize and thank some people that helped pull this together. First, Sabrina Corlett and Karen Davenport from the Center on Health Insurance Reforms. We had the privilege of working with them as part of a technical assistance program offered by the Commonwealth Fund that supports states that are seeking to implement commercial market affordability strategies. And a thank you to Baylor Health, which helped secure and facilitate Sabrina and Karen's work under the program. Also wanted to thank Jeff Batista even though he left the board about a year ago, he did a lot of work on this project. Thank you to Jackie Lee and Jason Doherty from Lewis and Ellis, who helped us work through some issues and also pulled together some data reporting templates that we haven't finalized yet, but if you move forward with this, are kind of ready to be finalized. And finally, thank you to Laura Beliveau, who also helped out with this project. So, kind of big picture, why did we develop this? I think that can be kind of summarized in just a few points. So first, Vermont statute directs the board to consider a number of factors when deciding whether to approve, modify, or disapprove a rate request. Specifically, the board is required to determine whether the rates proposed in the filing are affordable, promote quality care, promote access to health care, protect insurer solvency, are not unjust, unfair, inequitable, misleading, or contrary to Vermont law, and are not excessive, inadequate, or unfairly discriminatory. And the insurer who's filing the rates bears the burden of justifying its proposed rates under that standard. Obviously, there's a lot there. It's a pretty hefty standard. And we have established ways of analyzing or measuring some of those factors, but not others. So for example, as you all know, risk-based capital ratio is a measurement of insurer solvency. And we spend a lot of time in the rate review process talking about the insurer's RBC ratio. We also spend a lot of time talking about affordability, but we don't have a similar measurement for affordability. And the board has, over a number of years, I think, expressed a desire for better data, quantitative data regarding the ability of individuals to afford the rates that are being proposed. And then the final point is that, the board can require any party to a rate review proceeding to provide information concerning the filing. And so that's where this document comes in. So I'll just walk through it kind of at a high level, and then take questions. So section 1 here is really just describing the problem that we have here in Vermont with affordability, which you are all too familiar with. So I won't spend much time there. Moving on to section 2, this is describing the purpose of the document, which is really to assist the parties to a health insurance rate review proceeding by describing analyses that the board is going to request and consider in determining whether an insurer's proposed individual and small group rates are affordable. It's really giving the parties advance notice that the board will be asking for this information and considering this information when it goes to make its decision. That said, the parties can still submit other information regarding affordability if they want to, obviously subject to the rules of admissibility that apply, but it's not meant to preclude parties from arguing about this information or submitting other information that is relevant to that factor. Moving on to section 3, this is really describing the analyses that the board would be requiring insurers to submit. So subsection A describes analyses for the individual rate filings. Subsection B describes analyses for the small group rate filings. The analyses are identical, except there's a slight difference with respect to the premium analysis, and we'll get to that. I didn't explicitly mention it, so this just applies to individual and small group rate filings, not large group filings. We would like to develop something similar for large group filings, but that is more complicated due to the nature of large group rating. So at a high level, the guidance is calling for an analysis or measurement of plans, premiums, and cost sharing in relation to some well-established metrics in the Affordable Care Act and the Household Health Insurance Survey. It's just looking at standard plans, meaning those plans that have identical designs across insurers and are therefore comparable. And it's measuring the degree to which the plan's premium or cost sharing is greater than or less than the established metric. So we're looking at ratios, not a black and white. Is it higher? Is it lower? Feeling that ratio would give you more information, be more useful. So I'll just start with the premium analysis. This is going to compare an individual's premium or expected premium contribution to the IRS required contribution percentage. That required contribution percentage is also sometimes referred to as the affordability percentage because it's used to determine whether an employer-sponsored health plan offers affordable coverage for purposes of the ACA's employer mandate. The affordability percentage is updated annually. It's 9.02% for 2025, up from 8.39% in 2024. And just to highlight, this is not the same thing as the applicable percentage, which is the amount that the Affordable Care Act requires someone to contribute toward the cost of the benchmark plan, and is used to determine the amount of premium tax credit they're eligible for. So it's a different percentage than that. So in the individual filings, we're going to be comparing the affordability percentage to the net premium after any federal or state premium subsidies are applied. That net premium would be calculated using the proposed plans of both carriers. Just one thing to highlight around that is that the proposed premiums do change during the process. So we still need to work that out. Like, when would we be asking for this information? Maybe multiple times during the rate process. We have a form prepared, so that shouldn't be a big burden on anyone, but just to highlight that kind of complication. For the small group filings, the premium analysis would be comparing that affordability percentage to the expected employee premium contribution, which we define as the average share of premiums borne by employees at fully insured private sector establishments in Vermont with less than 50 employees, as published in the most recent MEPS data available. So that's survey data that is publicly available. Two kind of technical things to note here. The first being that that MEPS data isn't an exact match to how we define small employers in Vermont. We define small employers in Vermont as less than 100 employees. But it was the most close data point there. And then second, the MEPS data has, shown some variability from year to year, which is just something that I think we'd like to keep an eye on. And if it proves to be an issue kind of moving forward, we might want to consider using some sort of rolling average or something different than just the most recent year. Moving on to the cost sharing analyses, there are two of those, and they align with the Commonwealth Fund's definition of underinsurance which, as you all know, is incorporated into the Vermont Household Health Insurance Survey. The first cost sharing analysis is just looking at the plan's deductible as a percentage of household income. So that's pretty straightforward. The second cost sharing analysis is looking at a household's total cost sharing burden under different utilization scenarios, engaging how that compares to one of two standards that the Commonwealth Fund has that you'll see here. 10% of household income for households at or above 200% of the federal poverty level, and 5% of household income for those households below 200% of the federal poverty level. Moving on to section C, subsection C, this is describing the different utilization scenarios that that would be used for the total cost sharing analysis I just discussed. Jumping ahead briefly, Appendix A is describing the different households that would be included in those analyses. So for the premium analysis, we're looking at incomes in 10% increments of the federal poverty level. For the cost sharing analyses, because of all the variations there, that's a lot. So we're just looking at incomes in 50% FPL increments. And then finally, almost finally, subsection D here is kind of referring to work that we already do and are going to try to do better in the future. You know, as you all know, premiums are developed to cover the cost of members' care and provide a margin for the insurer to contribute to their reserves. Insurers have some degree of control or influence, varying degrees, over these underlying costs, and rate review is an opportunity for us to make sure that insurers are being effective in their cost control efforts. And so this is a nod to that. We have a lot of work to do, I think, in this space, but the idea, the hope is that we can improve our questions, possibly identify benchmarks, best practices, if they exist, and really kind of probe the reasonableness of the underlying costs better, and to actually affect affordability from the ground up. So that is all I have for you. Happy to take questions. I think the insurers and the healthcare advocate may have comments that they'd like to provide. We did notice this for a vote. It was subject to a public comment period last year, so I didn't feel that a further one was necessary, but that's kind of why I put a potential vote on the calendar for today.
Thank you, Mr. Barber. And I remember last year there was a lot of comment and we went back and forth, and I appreciate the additional year of time and work that went into developing this. And thanks for recognizing all the other folks who worked on this. I'll open up to the board members for any comment, and we'll see if there's interest in a vote at this time, or we can delay it if we need to. But any board member questions or comments?
Just like to make a comment, recognizing that after hearing from the HCA and any public comment, I might have a little bit more to ask, but I just would like to thank you, Mike and team, for all the work that you've done here. This is a remarkable effort. I think the measures that are in place will help guide the board not only in our rate review work, but also in our hospital budget review efforts. the medical trend is what drives the premiums and out-of-pocket expenses for the individuals in the plan. And so these measures will indirectly help us understand the effect our decisions on in the hospital review process. So it's very useful, very welcomed. I appreciate all the work you did on the process and what's here. It's well done.
I guess I would just add, similar to Tom, I think last year the public comment was incredibly helpful in framing this issue. So I may have more to say after some public comment and reviewing comment.
Okay, we'll turn to the HCA for any comments they have.
Sure. Just wanted to mention we fully support the guidance and to thank Mike. It's never easy to deal with screaming children, which we can occasionally be, myself mainly. I will, this year presents some unique challenges, especially with the potential cessation of the enhanced premium tax credits and how we've dealt with that in rate review in general is to submit rates with and without. And I think this year we may tragically have to do that with affordability too, because if that cliff comes back, I think it's going to be a substantial concern. Just quickly, and I think I've said this to Mike, is, in terms of working with the MEPS data, it would be Nolan at JFO. He uses it JFO uses it to calculate the basic needs budget. They calculate a lot of the measures in the guidance. And then I think I'm sitting on some Excel files to do the individual market, which I'd be happy to share or work with whoever at the board is implementing it, whether it be in Excel or a database. I'm happy to help folks with that. Thank you.
Thank you, Mr. Schulteis. Any public comment via raise the hand? Okay. I think I'm going to wait to take a vote. We might as well give ourselves a little time. I don't think there's a big rush. Mr. Barber, is that okay with you?
Yeah, yes, rate filings are due early May. So if we can get this done the next, couple weeks, I think that would be fine.
Let's put it on the agenda for next week. There's no reason to delay. I think that'll be enough time. And I think member Walsh's point's pretty well made. A lot of this affordability is not done in the rate review process. It's many other pieces that go to it. Okay. Well, thank you very, very much. Any new or old business for the board? Okay, one hearing left in member Lunge's career here, so let's all get ready for next week and send her off well. I will move we adjourn.
Second.
All in favor say aye.
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 Aye. We're adjourned. Have a good day.